So good afternoon, everybody. Today I'm going to present a case of Anasarca in the context of an elder onset lupus. So I'm very excited about this case because we usually have this type of patient that come for something and out of nowhere really he became lupus. So how did it start? So he was an 84-year-old Caucasian male with 1 week of exertional dyspnea, orthopnea, productive cough with clear sputum, left side pleuritic chest pain, oliguria, and anasarca. So right from the beginning, we have these type of patients and we think, okay, this sounds a little bit like heart failure. Is this new onset heart failure? Is this something like ongoing? Is this maybe pneumonia with heart failure, pneumonia or COPD? So we usually think about these three things. And of course, we went to the medical history and we realized that he was a former smoker. He had hypertension. So that really brought us into the idea of, oh, maybe this is heart failure. But then we also heard about this untreated interstitial lung disease, that it was basically mentioned by the history of a smoker. Somebody mentioned it at his primary care office. So it was never truly worked up, never had a CT in the past. And also he had some chronic back pain. He was on some medication, occasional Norco. Nothing really new regarding the back pain or any other joint pain. So besides that, on arrival, he actually came with some tachycardia on 101. Blood pressure was a little bit elevated, 168. Respiratory rate was 24, and he was actually requiring 3 liters of oxygen. He was never on oxygen besides having this untreated interstitial lung disease. So initially, we leaned more into this like a decompensated heart failure, sepsis type occasionated sepsis type by pneumonia. And on the physical examination, the positive was that he had some decreased breath sounds bilaterally. The abdomen was distended, diffusely tender, not specific, not requiring of any surgery. But the extremities were, we have some edema in the upper and lower extremities. On our workup, of course, we found that the patient had some elevated BNP. We were very high on the heart failure. We also found some new deranged renal functions. Creatinine was 1 on a previous PCP office workup. BUN was 40, so this was new. We thought this could be dehydration. This could be maybe his volume overload and the intravascular is depleted. And we started doing some tests, and I'm going to jump to the chest X-ray that shows some chronic bilateral interstitial infiltrates, mild cardiomegaly, but on the echo, it was a pretty normal echo. So we were wondering, okay, so the echo is normal, heart failure is out of the picture. Of course, the team decided just to give him some antibiotics, and we hydrate him. We were cautious with hydration at the beginning, but once we cleared him from the echo part, we realized, okay, let's hydrate him. And we realized that the patient creatinine didn't come down. And besides that, this interstitial lung disease, the CT shows some bilateral lung fibrotic changes with honeycombing. So it was more of a UIP pattern. And we said, okay, UIP pattern is a little bit more, it's not very specific of any autoimmune disease, except for rheumatoid arthritis, but not for lupus. But we said, okay, let's explore this renal function. And we realized that after 24 hours, protein in the urine collection, we realized that the patient was in nephrotic range. So we went ahead and did some ANA test. And we found that the patient had a positive ANA, 1 in 640, a speckled pattern, positive SSA, ROA. So it was a picture that was positive for Sjogren also, Sjogren antibodies. Otherwise, normal C3, C4, normal rheumatoid factor positive was high because this patient was having this interstitial lung disease. And then negative ANCA. After discussing with the family about the benefits and to aim for treatment, we went ahead and did class 5 membrane renal biopsy that showed class 5 membrane lupus nephritis. So actually the patient had lupus. This 84-year-old man had new onset lupus, and we treat him with steroids. He responded very nicely. So as soon as we got the echo, as soon as we got also the CT chest, we started with the steroids, but now we were reassured with the follow-up test. I dropped hydroxychloroquine and phenolate with dramatic improvement of symptoms, not only on the hospitalization, but also on a follow-up 1 month later at the rheumatology office. And we really learned that late onset lupus, it's just, they call it not because they have there has some specific symptoms, but because it happens after 50 years. And this patient had something that's common in this late onset lupus, that is Sjogren pattern. He didn't have any cutaneous symptoms. He didn't have any other signs of arthritis. He didn't have signs of photosensitivity. He'd have something that is more common in onset lupus than in people that have lupus and are 50 years younger. That is the interstitial lung disease pattern, because usually younger people with lupus may have pleuritis, but this patient had ILD. And besides that, the patient, the manifestation, the renal manifestation might not be that common in late onset lupus as compared to the other 50 and younger, but it tends to be more slowly progressing. And this patient presents with glomerular sclerosis, with membrane lupus nephritis, but he responded well to steroids. Creatinine also went normal. And this patient now is pretty much doing okay.
All right. Well, we have one question. Just keep
Yes.
track of time. The diagnosis of Sjogren's was listed. Did he have any evidence of dry eyes, mouth, or was this just assumed by the lab work?
So so it's sometimes it's very interesting because you may have elder people that have dry eyes and dry mouth just because they are elder people, but this guy didn't have anything like that. So it was just something found that it's some finding that it's also found in people that have late onset lupus. So it just kind of, but nothing really related to that. Even no signs of like lymphoma that sometimes could be associated with this pattern. Yeah.
Sure. That makes sense. All right.
All
Well,
right.
thank you for this presentation.
Thank you very much. Have a good day.